Well, good evening, everybody. Welcome. We are over the 100 participant mark here, so we are going to get started with this evening's forum, Understanding Primary and Secondary Immunodeficiencies. Welcome, I'm Kathy Antela, Vice President of Education at the Immune Deficiency Foundation, and I will be your MC tonight. As always, a quick disclaimer before we begin that the information you are receiving tonight is not to be considered as medical advice. Please always consult a healthcare provider with questions about your healthcare. IDF has been around for 40 years. And we have this wonderful mission of improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. And it is through this mission that we do our very, very best to make sure that IDF seeks to seeks to ensure that everyone in the US affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all their opportunities for connection and support within the PI community. Questions? Do you have questions? I know I sure do. I still have questions, and I've been with IDF. I've known of IDF since 1997. So if you have questions, whether you are an individual with PI, a family member, a friend, or a healthcare provider, IDF is here to help. When you have questions, go to our website, click Ask IDF. It's on the homepage, and send your question to us, and a staff member will follow up with you and do their best to answer whatever question you send. Support. Are you looking for other people in the PI community to receive support from, provide support to, network with? We have wonderful Get Connected groups, which are virtual opportunities for people to get together throughout the year, around the country, to get to know people in their neighborhood, people in another state maybe even, but to receive support, provide support, and just to not walk this journey alone. So if you're interested in our Get Connected groups, they are virtual. And I know there are some coming up this weekend. Just look on our calendar of events and you will see all of them listed there, and you register just like you did for this forum. Another way to receive support, if you say, yeah, you know, I'm not really a group support like person, contact Ask IDF. Say, I'm looking for some one-to-one support, and we will network you with one of our wonderful peer support volunteers. And of course, we have forums. Oh, and our next forum is coming up this week, or next week, March 9th, and it will be a lunch and learn about hyper-IgM syndrome. Registration is open, and you can again go to the calendar of events and just register for that event. And with that, the moment we've all been waiting for, the introduction of our wonderful presenters. And as I'm introducing our presenters, Dr. Walter, you just go right ahead. I'm going to stop share and you pull your slides up, and let's get this show started. But as you're doing that, I do have an official introduction for both of you. And I will start with Dr. Jolan Walter. She is let me get my notes here so I don't make a mistake. Dr. Walter is the Division Chief of the University of South Florida and Johns Hopkins All Children's Pediatric Allergy and Immunology Programs. And she is an international expert in primary immunodeficiencies and immune dysregulation. Welcome, Dr. Walter. And our other presenter is Dr. Mark Ballow. He is a physician at the University of South Florida and the Allergy Immunology Program at Johns Hopkins All Children's Hospital and a professor in the Department of Pediatrics at the University of South Florida, Morsani College of Medicine. He is also IDF's Consulting Medical Director. So we are so happy to have both of you here. We are so very lucky. And with that, I turn it right over to you.
Thanks, Kathy. So I'm going to just present a little bit of a blurb on secondary immune deficiency as kind of a background, and then Dr. Walter is going to address primary immune deficiency, and then we'll open it up to Q&A. So the definition you see here, secondary immune deficiency, and here we're talking about secondary hypogammaglobulinemia, is characterized by reduced immunoglobulin levels, either due to medication or disease process, leading to decreased antibody production or increased antibody loss, and also not great responses to vaccines, which is obviously important. It is challenging to distinguish between secondary immune deficiency and primary, and I'll give you an example of that in a minute. And the most frequent causes of secondary immune deficiency are to immunosuppressive medications, and we'll go over a case history where that is the case, or loss of immunoglobulins in the GI tract or urinary systems, that's more unusual, but does happen depending on the underlying disorder. So the largest proportion of secondary immune deficiency, hypogammaglobulinemia, is due to increased use of immunosuppressive drugs, particularly those that deplete B cells. So if you deplete B cells, you don't have plasma cells, and therefore you don't have immunoglobulins, and you can't make specific antibodies. And this also occurs in certain cancers as well. Next slide. So just some medication. Probably, well, maybe some of you are on some of these medications. So for example, for rheumatoid arthritis, I'm not a rheumatologist, but I don't think these are used anymore with the biologics that are available, such as gold and penicillamine and sulfasalazine. We have great biologics now, so I think that's not the case that patients are receiving those. But anticonvulsants can actually cause secondary hypogammaglobulinemia, particularly with things like Dilantin and reduction or deficiency of serum IgA is the most common secondary to these anticonvulsant medication. We really don't understand the mechanism how this occurs. Next slide. So the secondary immune deficiencies associated with hematological malignancies is like a double-edged sword. And here I'm talking about chronic lymphocytic leukemia, multiple myeloma, and lymphoma. And in that the cancer itself, because of dysregulation of the lymphocytes differentiating into B cells and plasma cells, can lead to hypogammaglobulinemia. And then, of course, we target the B cells with therapies like rituximab to deplete the B cells, which not only depletes the malignant cells, but also the good B cells, and therefore that results in hypogammaglobulinemia as well. And of course, here we're worried about the onset of serious infection that can lead to various morbidities, deficiencies, and consequences of quality of life, etc. Next slide. So we as clinicians are facing this dilemma every day, and Dr. Walter is going to address this in more detail. You know, which is the cart and which is the horse? Which came first? Is it an underlying immune deficiency that leads to a particular hematologic cancer, or is it the other way around? So we'll have a few words about that. Sorry, let me just, should have muted my phone. Oh well, I'll learn every time. So this is a little case history that Dr. Walter is going to expand on, but just give you an oversight of the kind of dilemma that we have to deal with of trying to sort out, which is the cart and which is the horse. So this is a 55-year-old female who was treated with 2 courses of rituximab 7 years ago for idiopathic thrombocytopenic peripheral. And this is a patient I actually saw in Dr. Hugh Wyndham's office in Sarasota. She had developed 2 episodes of pneumonia and was referred to us because the hematologist noticed that she had low serum IgG and absent B cells when he did some laboratory studies. Next slide. So her immune evaluation showed indeed that she had significant hypogammaglobulinemia, 260 milligrams per deciliter, a low IgA, and an IgM that was also a little bit low. She did not respond to vaccines. Well, this is something we routinely do with patients, give them certain vaccines to see how they respond to make specific antibodies. And flow cytometry showed that she only had 1% B cells, which reflects the fact that she was treated with rituximab. But that was 7 years ago. So why didn't her B cells return? Usually they return 6 to 9 months, maybe a year, depending on how many courses of rituximab, but this was 7 years ago. So the question is, does she really have PI? Did she have common variable immunodeficiency? Obviously, she was started on immunoglobulin replacement therapy because she had significant hypogammaglobulinemia. And then we did further genetic evaluation to show that indeed she had a monogenic abnormality in one of her genes that led or is responsible for the immune deficiency disorder. And as I said, Dr. Walter is going to explain in more detail. Next slide. So yes, there is an increase in hematologic malignancies in patients with PI. This is a large study by the US IDNet registry, actually, which comes under the umbrella of the IDF. You can see a large number of patients between 2003 and 2015. And there was I would say, a small increase, a 1.4-fold increase in the relative risk of cancer in PI patients versus the general population. And these were lymphoma mostly. Next slide. And just to remind you, many of you probably already know what rituximab does. It's a monoclonal antibody, a therapeutic antibody that's directed against a receptor on the B cell, happens to be CD20. And therefore, this interaction essentially leads to the destruction of B cells. So these B cells can't differentiate into plasma cells to make specific antibodies. Next slide. So we now recognize, it's most of these articles are not that old, but we now recognize that prolonged hypogammaglobulinemia and severe B cell deficiency can occur with infection following rituximab, and these patients need immunoglobulin replacement therapy. Next build. And we also recognize that if they receive an immunosuppressive therapy along with the rituximab, so for example, some patients with rheumatoid arthritis receive not only rituximab, but also methotrexate. And we know that that kind of enhances the secondary immune deficiency. And that may also occur in certain cancers as well. And it impairs vaccine responses, as I showed you, as I alluded to. And therefore, we want to try to immunize individuals before restarting rituximab if possible. And one of the things that we're, as clinical immunologists, we're beating on our colleagues in both hematology and rheumatology and other disciplines, that if you're going to put somebody on rituximab, please get baseline serum immunoglobulin levels and enumeration of peripheral blood B cells, so that we don't run into this issue of which is the cart and which is the horse. further on down the line when the B cells do not recover. And then we're left with a dilemma of whether they have an underlying primary immune deficiency disorder. Next slide. Just a word about CAR T-cell therapy. Some of you may have heard about this. It's called CAR, this chimeric antigen receptor. It's a novel treatment for acute lymphocytic leukemia, particularly in children and adults with B-cell lymphoma. And it's like science fiction. It really is. What they do is they take the T cells from the patient and then they change them in the laboratory so they can the patient's cancer cell. And it's really turned around, particularly in those individuals who have become resistant to their chemotherapy. So it's a new form of therapy, and it's amazing of what it can do. Next slide. But it can result in severe hypogammaglobulinemia and other immune dysfunctions as well. Next slide. So this is my final slide, and I just want to show you that secondary antibody deficiency is not straightforward, and this is somewhat what we have to deal with. And it can be divided up into different categories. I alluded to the fact that B-cell lymphoproliferative diseases or hematologic disorders, such as multiple myeloma and CLL and others. Drug-related, I alluded to that already, particularly those that target B cells and eliminate B cells. Patients that are undergoing organ transplantation may develop a secondary antibody deficiency because of the immunosuppressive drugs that they're on. GI loss, renal loss from the lymphatic system, and then other more rare conditions that can lead to secondary antibody deficiency, not so much in this country like malnutrition in third world countries, but certainly HIV infection and others related infections can also result in secondary antibody deficiency. So it's complex, and that's, as clinicians, we have to try to sort that out. So let me hand this off to Dr. Walter, and she's going to kind of bridge this issue about which is the cart and which is the horse of trying to sort out, at least from our perspective, whether we're dealing with a secondary antibody deficiency or a secondary immune deficiency or a primary immune deficiency. Dr. Walter?
Thank you, Dr. Ballow. Can you hear me well? Dr. Ballow, can you hear me?
Yes, I can hear you.
I just wanted to make sure that my voice is transmitting well. So first of all, I would like to thank the IDF and Dr. Ballow for the opportunity to talk with him. He's a world expert in immunology, and I'm always excited to partner with him and talk about immunodeficiencies, especially how to sort of dig deep and understand what is going on in a patient when they develop low antibody levels or low vaccine titers. So when I think about primary or secondary antibody deficiency, I like to use the parallel of the chicken and the egg, which is similar to the horse and the cart that Dr. Ballow just mentioned. And basically, when we think of primary immunodeficiency, that is an inborn error. There could be a genetic code behind that, and we will discuss it in a minute. And then this acquired or secondary immunodeficiency would be the one that is triggered by drug, cancer, chronic illness, as it was presented in the slide before. And when you contrast the two diseases, it's actually very telling, this table, how different they are. So primary immunodeficiency tend to be more in pediatric patients, although we are discovering more and more adults later in life with this condition. And then secondary immunodeficiencies are presenting more in the adult adolescent group, since they are the one who are going to be treated with drugs and have cancer or chronic illnesses. And the diagnostic workup is going to be very different. If you think of a primary disease, you want to do immune profiling and genetic testing, and we will detail that later. But for secondary, you really want to go after the triggers, like what could be a trigger that created this low antibody level. And most of the clinicians would go after that before they think of immune evaluation, which we think is probably should be more equal. The treatment could be very different. I will touch on that. In case of primary, we are more ready to treat with immunoglobulins, go forward with targeted therapy, or even bone marrow transplant, which I mentioned here as HSCT. Whereas in secondary, you want to go after the trigger and try to find the trigger and treat it. And then regarding the incidence, it could be very different. We think that we're going to find more patients with secondary immunodeficiency than primary. But the question comes, if they are secondary, are they truly secondary? So that's going to be my first discussion. And then if we prove that they are secondary, who should we treat? So we're going to talk about those two main topics and contrast the PID and secondary in that matter. So just sort of recapping what is important in primary immunodeficiencies, you all remember that many of the patients would present with infections that is in this big red circle on the left, and those patients who have infections would get antibiotics and immunoglobulin. But our understanding is growing about the non-infectious complications, which are sort of these other circles listed here, the severe allergies, autoimmunity, inflammation, malignancy, and lymphoproliferation. And what we learned throughout the years is that not only patients can present with it during their saga with immunodeficiency, but these are disorders that will stay with the patients because they are hard to treat. They actually may precede infections, so it could be misleading that a hematologist will see the patient first with the autoimmune disease, and then they come to us as the second step. And most of them would have multi-autoimmune disease. So this is a very daunting table, and I don't want to overwhelm you with the information, but I will want to show you a few take-home messages from this table. When you think of an autoimmune disease, again, you can think of infections or autoimmune disease or the combination of the two. And I listed a couple of different conditions on the top of the chart with correlating genetic information. And what you can really take home from this chart is that wherever there's a plus sign, that means that it is present in that type of disease. And these are all these different autoimmune disorders that you can have in combination with infection. I want to emphasize that thyroid disease, arthritis, even alopecia or vitiligo, which people don't consider as an autoimmune disease, they don't even report it to us. These are all autoimmune manifestations. And when they happen in combination as a multi-autoimmune disorder, you really have to worry about an underlying primary immunodeficiency. And in particular, a disorder called PIRD, Primary Immune Regulatory Disorders. I'm going to spend a little time on that condition because you really need to understand if your disease have that combination of immune dysregulation with the full immunodeficiency. So what we know about PIRD is that they are highly enriched in autoimmunity with overlapping phenotypes, and I will explain it to you in a minute. And larger cohort studies are now available with very specific gene defects. So once you know what is your gene, it is much easier to understand the progression of the disease and how to treat it well. So this is a very simple Venn diagram of the clinical phenotypes of PIRDs. Most of the patients that you probably know of would have a CVID phenotype. So they present with low immunoglobulins, as you can see in the middle of the chart, and worsening B cell function. Whereas there are some patients who actually will have this ARPS-like phenotype. ARPS stands for autoimmune lymphoproliferative syndrome. And these patients on the left would have normal IgG, but they would have a lot of cytopenias and lymphoproliferation. So this is a very distinct entity, and it can be a little bit misleading for the clinicians because the IgG will be normal. And then there is a third phenotype of PIRD, which is called the IPEX-like. This one would have a lot of autoimmune disease affecting the hormones, the endocrine system, type 1 diabetes, thyroid, enteropathies. So again, PIRDs have a combination of these different phenotypes, and depending on what stage a patient is in their life, there would be a combination. So how to diagnose and track these PIRD patients? We are actually coming up with a very extensive immune phenotyping, which starts with the typical immunoglobulin levels that can be normal, vaccine titers and lymphocyte subsets, and then unique immune cell subsets. And these are just listed for you so that if you ever encounter them in your journey, in your immune testing, you would understand that some of them are more telling for a CVID-like or ALPS-like or IPEX-like group. However, most of your immunologists or clinicians in the community would say it's too complicated, too hard to access this testing, so they probably would choose a genetic evaluation for PIRD. And I think it's a very reasonable approach. Not everybody will be able to get all these unique developmental immune testing, and it's better to go for genetics. So what we learned is that by looking at the genes, the gene testing, there is a handful of genes that are linked to PIRDs, autoimmunity and immunodeficiency. And these genes are very well defined with large cohorts. So again, the clinician would be able to draw from that information and help you to get a better treatment strategy. So again, if you think about this inborn error or primary versus acquired or secondary immunodeficiency, who is at risk and who need immunoglobulin replacement therapy? PID patients more likely would need IGRT, especially if they have antibody deficiency. But how about secondary immunodeficiency? There is a lack of consensus between specialists when to treat and how to treat this patient population. So I sort of created this algorithm. It is not published in any special way, but I thought it could be meaningful for you to think of when to start immunoglobulin when there's a possible secondary immunodeficiency. So Dr. Ballow has mentioned that he had a patient who actually came after anti-CD20 therapy with a low IgG. So you would probably like to do a pre-treatment workup for a patient before they get rituximab or any kind of intervention, and then follow their immune phenotype after the therapy. So what would you like to follow? Infectious history? You want to follow IgG level, and in particular A and M, vaccine titers, immune subset, and possibly genetics. And if these are getting abnormal and there is especially history of infection or worsening immune problems, then you have to consider starting immunoglobulins. And when this patient is in immunoglobulin, they were going to ask, how long do I have to take this medicine? Is there a way for me to know when I'm ready to come off immunoglobulins? And that would be a special challenge, a neoantigen challenge. We are not having vaccination with salmonella. The SARS-CoV-2 vaccine is another option to have a neoantigen challenge. If patients are recovering their IgA or IgM compartment, that's already a good sign of B-cell immune reconstitution. And we can actually look for the B-cell subset themselves. So at some point, the patient could come off immunoglobulin replacement therapy. So again, how to distinguish primary from secondary? Clinical history of high importance. You want to look at multiple autoimmune manifestations, progression with age, and complicated treatment with refractory course. That is all telling for an underlying primary immunodeficiency. Family history with variable penetrance of disease, including infectious and non-infectious complications, could be helpful. And the basic immune phenotyping, although you have unique subsets, but the basic immune phenotyping could be very falsely reassuring. So you really have to go for genetics at least and look for biomarkers to help with your diagnosis and treatment response. Once you have a diagnosis, not only you can control the disease better, but you can bridge the patients to a possible hematopoietic stem cell transplantation. So in our center here in Florida with Dr. Ballow, we believe in a multi-center, multidisciplinary approach when clinicians of all backgrounds are working together. And this is just an example of how Johns Hopkins and Joseph Children's Hospital, Morzani at USF and Moffitt Cancer Center is creating a joint platform to take care of these patients from all these different angles of hematology, oncology, rheumatology, pulmonary, and immunology. So this is the last part of my slide. I'm very excited to be here with Dr. Ballow and to speak out for IDF, and we are here ready for your questions. Thank you.
Thank you. Thank you to both of you. Amazing information. And before we go into the Q&A, as always, there will be an email sent out to everybody who registered for this forum tomorrow. There will be a link in that email that will bring you to a survey. Please answer the questions in the survey to let us know how we did tonight, and also to share suggestions for future forum topics. We would really appreciate it. And also in that email, there will be information about how to view the recording. in the upcoming week. And of course, any questions, just contact IDF and we will do our best to answer any questions you have about the recording, the forum, anything else. And at this time, I am going to introduce my colleague, Colleen Brock, and she is the manager of medical programs at IDF. And she is going to moderate the Q&A with Dr. Ballow and Dr. Walter. Colleen, I'm going to pull my slides down and you take it away.
You have some awesome questions. So I hope Dr. Ballow and Dr. Walter are ready because they just keep coming in. I will do my best to answer or ask all of them. But if by chance we don't get to all of them, please know that you can reach out to Ask IDF on the website and ask your question through there, and we will see that you get an answer. So we're going to go ahead and get started. What lab panels would help determine if CVID is a primary or secondary immune deficiency?
Go ahead, Jolan. You're the lab person.
Thank you so much, Mark. So I think this is a tricky question because it depends on how far are you out of the B-cell depleting therapy. If you never receive B-cell depleting therapy and you have not received any biologicals and you have CVID, the likelihood of having a primary immunodeficiency is high. But if you receive biologicals, I think you have to be mindful about the interaction and the timing. But I would definitely look for B-cell counts, in particular, the total B-cells and maybe the switch memory B-cells. It would be very useful to look at. And then you can also look at IgG, IgA, IgM levels and vaccine titers, and that together will be all informative to diagnose you with a true CVID versus a secondary antibody deficiency. Mark, do you have any other comments?
Yeah, I mean, again, it depends on the immunosuppressive medication that the patient is receiving and the history. I mean, are they getting immunosuppressive because of an organ transplant, or are they getting it because of a malignancy? Because then interpretation of the lab test makes it very difficult to try to sort out whether they have a primary immune deficiency. It just can't be done. It has to be done, after the patient's been off these immunosuppressive drugs for a while. And as I showed in that case history, that patient was off rituximab for 7 years. And we know normally that the B cell count should come back 9 months, 12 months, maybe a little longer, depending if they have, like methotrexate also on board, but not 7 years. So that patient was suspect already. But yeah, while the patient's on immunosuppressive therapy, it's very difficult to use the labs to sort out whether they have a primary or secondary immune deficiency, more likely a secondary immune deficiency. Unless we go right to genetics or there's a family history. So if there's a family history of someone else in the family, a history of recurrent infections, perhaps with some autoimmune disease, that's suspect. And in which case, the genetics doesn't change no matter what kind of immunosuppressive drug you're on. The genes are the genes. I hope I'm saying that right, Jolan.
Absolutely.
That may be one way of sorting it out.
Yes, I think you recapped it very well. Yes.
So kind of along that line, if it's a non-familial hypogam, is that considered secondary or primary?
No, I mean, these immune deficiencies don't necessarily are represented by other family members. But I will say there are many examples in the literature where what we call the Proband, that is the patient that comes to light and is worked up by the clinical immunologist that clearly has an underlying immune deficiency. And you look at the brothers and sisters and you look at the parents and they don't necessarily have a lot going on clinically. And there again is where genetics comes in, because we can look at the genes of the brothers and sisters and the parents and see that, wow, even though they're clinically well, they still have the same gene. And Dr. Walter will explain this further. Just because you have a bad gene doesn't mean it's manifest in disease. It's something called variable penetrance. Jolan, do you want to explain that a little bit more?
Yes, and then actually, I just want to bring an example of a patient that we are recently following with 3 siblings and a mom. And the mom had a lot of infection when she was younger, and nobody ever really paid attention to it. But once her son was diagnosed with an immunodeficiency, it became obvious that they both have the disease. And the other 2 siblings were relatively well. So if he didn't have the diagnosis, the genetic diagnosis, nobody would care. So we actually screened the whole family, and all 4 of them had the same genetic disease. One of the sister actually had very severe complications from COVID. So I think it's very important that once you have a gene in your family, to try to encourage everyone to get an understanding of that, having it or not, because we are more prepared to face complications down the road when we know that somebody carries a gene, even in a relatively benign clinical presentation.
Thank you. Does interferon create secondary immune deficiency?
Does interferon is extremely important cytokine in helping us fight off viruses. A good example of that is actually COVID-19, SARS-CoV-2, in that there are some people that are born with genetic defects that can't either generate certain types of interferon, or the receptors in the cells are defective for interferon, or some of the other enzymes in the pathway are genetically defective, and they have an increased susceptibility to severe COVID. So interferon is important in protecting us against infection. I think, we're learning a lot about COVID, and particularly the relationship of interferons, but that's true with other viral diseases as well.
I would probably add that we do have therapies with interferon for certain disorders, like CVID, or sometimes patients who have hepatitis infections, hepatitis C can get interferon therapy, and it is a double-edged sword in some cases, because giving interferons can, of course, cause a bit of an immune turmoil as well. So the interferons can be very helpful, but if there are too many, it can be harmful. So I think it's a balance that we all have to understand for the patient, individual patient. Colleen, you are on mute.
Sorry, my dog is barking. Is Good syndrome a primary or secondary immunodeficiency?
It's a primary. It's actually a primary immune deficiency. Many of these patients have thymomas, and when you take the thymoma out, sometimes they correct their hypogammaglobulinemia. I am not sure about the genes. Have we discovered any underlying genes that are associated with Good syndrome?
So this is an exciting topic, because we all know that Dr. Robert A. Good, who you trained with and you have been working very closely, is he has the name behind the syndrome, and there are no genes so far identified. But curiously, we recently found, and we will present at the CIS, antibodies to lymphocytes in this disease. So somehow these patients acquire anti-lymphocyte antibodies with age, as they age. And then these anti-lymphocyte antibodies could potentially push them into a low B cell, low T cell state when they become hypogam and susceptible to viral infections. So if any of you have family members or disease itself with Good syndrome, we would love to hear from you and have you in our studies, because this is an ongoing active research. And I think Good syndrome probably has some predisposition, but it becomes acquired maybe later in life. The disease doesn't come out until they are 50 or 60-year-olds. So it's a combination probably of primary cause and then other triggers together that create the syndrome. That is sort of my understanding, but Mark, please correct me. What your thoughts
Well,
are?
I think under the classification of the IUIS, it's considered primary, although there are some components that suggest that there's secondary stuff going on if there's autoantibodies against lymphocytes. So we have a lot to learn, even though it's been recognized. I think Dr. Good maybe published it back in the 60s, I think.
Yes.
Good syndrome.
Yes.
Can you have both a primary and a secondary antibody deficiency at the same time?
Yeah, I mean, absolutely. I mean, we see that all the time in patients with common variable immunodeficiency who have an underlying primary, and if they're treated with an immunosuppressive drug like rituximab because they have autoimmune disease, they have a secondary, or if later on in life, as I said, a small number of patients may develop lymphomas. And because of that, they may have, dysfunction or deficiencies in the B cell pathway that will also lead to hypogammaglobulinemia. But, they're on a replacement immunoglobulin. So that certainly will help with the infections.
Yes, I think, Mark, you have a very important point here that when we are having a genetic disorder from birth, it doesn't necessarily present itself in the full picture. And you have the triggers. These triggers are the secondary triggers that would push the patient into the combination of both. So I fully agree that sometimes you have a primary cause that sort of evolve into a combination of primary and secondary.
Thank y'all. How about, is there such a thing as having a partial immune deficiency? One immunologist said that a person might have a partial versus a full immune deficiency.
That's like being partially pregnant. I don't understand that. I mean, now the manifestations may be variable. As I said, some of the immune deficiencies have what we call variable penetrance. So those that we understand that are, genetically have a genetic relationship. So what may be seen in one family member may not be seen in another, or one patient may have a different quote phenotype or difficulties than another patient as a member of the IDF community. But I wouldn't call it a partial immune deficiency. I would just call it just a variable phenotype, partial penetrance. I think is a much better way of thinking about it, because if you use that word partial, patients may think, or the physician may think, oh, it's not a big deal. It's not significant. And I don't think about it. I think we have to be vigilant, even if somebody, doesn't manifest all the usual manifestations of a particular type of immune deficiency. They have to be followed closely.
There are a couple of disorders when we have used partial in the name of the disorder, such as partial DiGeorge syndrome or partial reg deficiency, when basically the disease is, as Dr. Ballow said, not fully manifesting. But that partial only means that sometimes they are not having the full disease regarding the full immune deficiency, but partial deficiencies can actually prone for more immune dysregulation, more autoimmunity. So having a partial reg deficiency or partial DiGeorge could actually start opening up a whole list of new complications in our patients with immune dysregulation. Maybe that's what I meant by the partial disorder, that partial DiGeorge or partial reg deficiency when you have hypomorphic variants. What do you think, Mark?
Yeah, I mean, I think let's look at hypogammaglobulinemia. I mean, we certainly classify patients as severe hypogam, moderate hypogam, based on the serum immunoglobulin levels and also the responses to vaccine. So I don't call those partial hypogammaglobulinemia. I would rather kind of look at it that way, whether they have mild, moderate, or severe hypogammaglobulinemia. And, along with some of the other immune parameters, such as vaccine responses, is how we stack those patients up.
So the next question is very fitting after your last comment. Does PI have an effect on infertility?
Well, there are some patients that can make autoantibodies to, for example, sperm, and therefore there may be some difficulty with fertility. I don't have the data off the top of my head, but I know that's been reported.
Yeah, patients who have air deficiency, like a problem with the selection of the T cells in the thymus, can come with endocrine abnormalities, hypogonadism, that of course makes fertility harder. And we also follow these hypomorphic or partial like deficient patients, and some of them actually had problem with fertility. So I think fertility could possibly be linked to immune dysregulation, autoimmunity in some of the cases.
And that can be worked up. I think that can be
Awesome.
evaluated.
How frequent is arthritis in patients with IgG2 and 3 subclass deficiencies and an IgA deficiency? And how would you treat it?
How common is it?
Yes.
I
You
can't
have
give you.
IgG2 and 3 subclass and IgA deficiency.
Yeah, I can't give you a percentage. I can tell you that in patients who have selective IgA deficiency, autoimmune disorders are common. All types of autoimmune disorders, including rheumatoid arthritis, but also, autoimmune endocrinopathies, etc. And the treatment is the same as anyone else with a inflammatory arthritis.
And I would think that if you have arthritis and low immunoglobulin subclasses, you have to start thinking about the T cells as well, because when you get into these non-infectious inflammatory autoimmune complications, there could be a role of the T cells. So I would probably ask the clinician to look into T cell compartments, possibly do genetic testing, because depending on where you fall, which category, you may have a higher chance of having treatment refractory arthritis when you are not responding to conventional therapy. So there's a lot of work to be done when you have arthritis and antibody deficiency, and I would try to pursue as broad evaluation as possible.
Does having genetic CVID versus acquired CVID change the therapeutic option?
Hold on. I'll give you a chance to respond first.
Mark, I like when you say things, it's so much more eloquent. So please go ahead.
Yeah, I don't think of it as acquired CVID. We don't understand why many of the patients with CVID start to have clinical issues in the 3rd and 4th decade of life, or even later. And we now understand, I don't know, Jolan, 40% of those patients, maybe 45% now, we can identify some underlying genetic issue. But why the onset is so late rather than in childhood, we don't know. There's obviously other factors that perhaps modify the expression of the gene that's affected that leads to immune deficiency. And, we're trying to understand that more, that there may be what they call epigenetic factors that maybe change the expression of the gene or modify it or whatever, so that later in life, patients develop common variable immunodeficiency. But, common variable immunodeficiency has lots of different names. In the old literature, it was called acquired hypogammaglobulinemia. Some people call it adult onset immune deficiency. So there's lots of different names for this phenotype that's very, very broad. And that's why we try to understand it. And we're making a lot of progress if we can identify an underlying genetic abnormality, because that will really point us in the correct direction, so to speak, that some of these patients may benefit from not only replacement immunoglobulin therapy, but also certain biologics, or now small biologic molecules.
So the interesting point is that the diagnosis of CVID comes from the combination of low IgG with A or M and low vaccine titers. And if you think about this question, whether there is acquired CVID, so CVID that would be like secondary generally don't have that low IgA or the low vaccine titers. So just by seeing a patient who is hypogam and seeing the absence of IgA or the low vaccine titers is already pushing them into that primary category and full CVID. So in that sense, I think acquired CVID is not really a term, because once you get a low IgA and low vaccine titers, you are really sort of heading to that primary category from the secondary, right?
Is CVID classified as low, moderate, or high hypogam?
All of the above. I mean, it depends on the patient. Some patients just have a very mild reduction in serum IgG and may have just recurrent sinusitis. And then other patients may have a much more severe hypogam where at presentation, the IgG is under 300 milligrams per deciliter, and they've had a history in the past of pneumonia. So it's all CVID. We just, use that kind of classification together. Remember, not alone the serum immunoglobulins, but together with the other parameters such as T and B cell subsets and vaccine responses to try to understand and pick our therapeutic direction.
And I would like to add, can I just say something?
Ahead,
sorry,
sure.
Because I think this is an important matter. He mentioned high too. So CVID would never have high IgG, although combined immunodeficiency, which is an even more severe version of immunodeficiency, can run high IgG for a while, because they are so inflammatory that they would run the IgG high. They include PI3 kinase deficient patients, even CTLA4. So when you have a CVID phenotype, but you have high IgG, it is even more important to have genetic testing and look for these underlying genes and see if you have a combined immunodeficiency, where the definition is going to be very different with T-cell abnormalities and underlying genetic defect.
Yeah, and particularly in those entities that you mentioned, the IgM is the one that's high. At least in PI3 kinase deficiency, the IgM is high.
IgM runs very high, and sometimes in the initial phase of the IgG could be high, and then it's sort of trailing down with age.
Yeah.
So depending on what age you find the patient, you would have very different immune phenotypes.
Speaking of age, we have a wonderful woman who is on here tonight with us, who is 80 years old. She says, I have, to my knowledge, never had cancer nor any autoimmune diseases. Over the past 20 years, I've had an increasing number of infections, sinus, bladder, ear. When I got a gut infection 4 years ago, my immunoglobulins, all of them were low. What is going on? I don't seem to fit the pictures you describe.
No, she does fit the picture. Charlotte Cunningham Rundles at Mount Sinai in New York has published extensively on patients with common variable immunodeficiency, and in her cohort, about 25% of the patients actually had infection only and didn't have some of the other immune dysregulatory issues that we were talking about. Enlarged spleen or livers or lymph nodes or autoimmune disease, etc. They just had infection only. So this patient may fall in that 25% of the group we call common variable immunodeficiency that presents with infection only. These patients can get GI infection and get pretty sick. And we know, for example, norovirus is really tough in these patients, as well as Giardia and, and other types of enteric infections, and be very difficult to treat, very difficult to treat.
And congratulations that she's 80 years old.
I
That's
know.
fantastic. I would say, though, that there is a term called immune senescence, or the aging of the immune system. And as we are getting older, our immune cells may not function as well. We don't know how to turn this around yet, but there's a lot of research going on how to slow down immune senescence. And maybe that's the reason why she was so well earlier, and now she has all these problems, because her immune system seems to go through that immune senescence earlier. And it's still unclear to me whether there would be a primary immune deficiency or something very little, or is it truly a primary immune disease? It will be unclear until she gets full testing.
Yeah, and seeing her an immunologist is the way to go. Does prednisone affect testing for your immune system when you go through the tests?
Depends on how much the patient is on it and for how long. So if they're on 20 milligrams daily for a while, yes, that could affect the testing.
Would non-Hodgkin's lymphoma come before CVID or after it?
At any time, before or after.
Can you please explain the neoantigen challenge?
Jolan, take it away.
Yes. So when we think about neoantigen, we basically want to find something that the patient has not received passively, like antibodies to it. And immunoglobulins contain a lot of antibodies that healthy people around us make to the viruses and bacteria. So we have to look for something that has not been seen by the community where the immunoglobulin is coming from. And one of them is actually salmonella. Salmonella infection is quite uncommon. And this is why we can use salmonella immunizations and response, because it would not be masked by the passive use of immunoglobulin in the patient. And we have similarly, at the beginning of the pandemic, could use, when the vaccines came out, the vaccination to SARS-CoV-2 as a neoantigen, and see how the patient responded to that. So this is a very useful method to test your specific antibody response while you are still on immunoglobulin without stopping the medication.
Unfortunately, we don't have a lot of time, so I'm going to try and do some real quick ones, some genetic questions. Is there an immune deficiency genetic panel that encompasses all of the immune disorders?
Yes.
Do you know the name of it?
It's the immune deficiency panel. Actually, they broadened it. They call it now the immune deficiency panel plus cytopenias, I think. Isn't that what they call it now? It covers 450 different genes that are linked to primary immune deficiency.
Pass the test, Dr. Ballow.
It's actually already 570 something. So they went even
Really?
higher.
Just since yesterday, they increased it to 570?
It was 407, and then the new one from January came out was 570 something. But what is interesting is that we believe that there will be even more immune genes that are involved in disorders, but it's very hard to keep up with it. So some centers believe in whole exome sequencing when they actually go after all of the proteins coded by our genes, and hope that way we can discover additional genes that are beyond this larger panels.
Is it too late to have genetic testing done once you have started replacement therapy? And secondly, where do you go to get that genetic testing done?
No, it's never too late. It has nothing to do with immunoglobulin replacement therapy. You have to be referred by a physician to get the testing done, but it's relatively inexpensive. And you can ask, I don't know what the mechanism is, your physician can ask the IDF, I guess, where to get the testing. There's a couple of different labs. We happen to use 2 different labs, Invitae and the other is what, Blueprint?
Use Blueprint.
Is that right, Jolan?
Yes. Mm-hmm.
Yeah. But
I think so go ahead.
No, I was just going to ask, would a genetic panel reveal the PIRD genetic mutation, or is that just done in research settings?
No,
No,
all
that
of
would
these
reveal.
mutations in on the panel. Yes,
Perfect.
they
Yeah.
are. Mhm.
But I think, Jolan, why don't you say something about VUSs so patients can
Mhm.
know that it's, even though we can get genetic testing, it's often complex, the interpretation, and the expectation of the patients may be, well, we have to hold the expectations down sometimes.
Yes. So when I order genetic testing, I always tell my patient that if you don't get anything back that is pathogenic, like truly pathogenic, it's sometimes a good news because you don't have any of those bad genes or bad diseases that can make your prognosis worse. So sometimes not having a gene that we find is also could be helpful. The companies that are now coming out with targeted therapies actually support genetic testing. So if you have a disease that has non-infectious complications, you can have free genetic testing from many of these companies because they want to enhance the identification of patients. So make sure you discuss that with your physician if there's free genetic testing because of your presentation. And then when they get back the report, sometimes they find this variant of uncertain significance that either could be pathogenic or disease causing or benign. And the physician have to think it through with all the information in the report, whether they take it seriously or not. So what we learned through this process that in a few occasions, these VUSs were actually helpful because we could eventually confirm that it was disease causing, but it's a tedious process. So when you look at your report and it says pathogenic, it's obviously important, and it is telling you that you are carrying a gene or you are affected by a gene that causes disease. But VUS resolution, this variant of uncertain significance really need your physician's interpretation. I would not drop it, but I would not pay too much. I would not worry too much about it.
And the other point, just to expand on that, is that the VUS is, they've detected an abnormal sequence. And what the genetic company does is they look in a database and they either find the sequence, the abnormal, whatever, the substitution or deletion in the database, or they can't find it in the database. And if they can't find it or identify previously, they call it a variant of unknown significance. But as Dr. Walter said, that, maybe next year someone will publish that particular abnormality, genetic abnormality. So now it is not a VUS, but actually an abnormality of significance. And if you've had genetic testing a long time ago, say 5 years ago, it may be worth redoing it, because I remember 5 years ago, maybe they could do 50 genes, 40 genes? I don't remember. It was a small panel. And so if it's been some time, and it may be worth, depending on the difficulty with your particular PI and the treatment thereof, it may be worth redoing the panel.
Perfect. One last question, and I apologize to all of you that we did not get to. Again, you can go to the website, you can ask IDF, we will be happy to answer your questions. But we're going to end with, I have normal IgG levels with the exception of my IgM. It is very low. Is there anything out there for therapy?
Depending on how low it is, I mean, there are a group of patients with selective IgM deficiency. Dr. Gupta in Orange County in California has actually published on this extensively, and some of these patients do have increased infections and autoimmune disorders. And he thinks it's worthwhile challenging these patients with vaccines to see how they respond, to make sure they can make specific antibodies, for example, like to Pneumovax. And he has found if they don't respond normally to vaccine, he has used immunoglobulin replacement therapy. We cannot replace the IgM. there's, at least in this country, we do not have any specific products to replace the IgM.
Thank you so much. The questions are phenomenal. Your answers have been fabulous. And I think everybody here tonight has learned that you can develop a PI at any point and to ask your questions to your doctors, to keep investigating your issues, and that IDF is here to help. And with that, I'm going to turn it back over to Kathy, but thank you.
Thank you for the opportunity. It was great talking to you, Colleen and Kathy. Thank you.
You too.
Yes, thank you. And thanks to the audience. They were great questions.
Yes.
They were very insightful. They were fabulous questions.
Very.
I agree. Thank you, Dr. Ballow. Thank you, Dr. Walter. Thank you, everybody who submitted those questions, because as we've said before, those questions help make these forums as wonderful as they are, especially when we're challenging these brilliant minds that Dr. Ballow and Dr. Walter have. And thank you both for volunteering your time to be here tonight. And with that, I would like to move on to thank our featured sponsors tonight, who were CSL Behring, Grifols, and Takeda. And then again, to thank each and every one of you for being here tonight, for sending your questions, and please take care and enjoy the rest of the evening. Good night.